Onc Live Insights is a video editorial program produced by Onc Live.
Poor risk patient is a very special group of patients. First of all, it's very heterogeneous. And when you look at the poor risk factors, one is largely above every other factor, which is performance status. So we have poor risk patients with poor performance status, which are almost patients who are almost dying. And we have poor risk patients with good performance status. So in poor risk patients with poor performance status, I still use temsirolimus. First, because that's the only drug approved. Second, because patients came every week to the hospital, so at the same time they can see the palliative care unit and so on. So that's a convenient drug to use. In the good performance status, even if they are poor risk features, I usually prefer to use TKIs as first choice.
The question that often arises in poor risk patients, because we only have the trial with showing the benefit of the use of weekly IV temsirolimus, whether this can be changed into whether we can just use everolimus instead of temsirolimus because it's easier, it's again an oral treatment, you can just give the prescription to the patient and that's it. I don't think that it's interchangeable. I do think that the side effects are clearly used in the dosage of temsirolimus, 25 milligrams IV weekly, as compared to everolimus oral 10 milligrams per day. That the side effects differ in the different trials, of course, and not a head-to-head comparison. And also the kinetics are different. It's probably daily dosaging. So chronic administration of an mTOR inhibitor is probably better than IV administration. But of course, formally we do have the phase 3 data for the IV temsirolimus treatment in poor risk patients. So formally we should stick to temsirolimus, but as I alluded to, I think in daily practice what happens is that a number of patients will receive oral everolimus, and personally I don't think that that's a bad choice. And on top of that, I do think that also poor risk patients will also receive upfront TKIs instead of an mTOR inhibitor, and then if they're able to tolerate upon progression a second drug, then you will switch to the alternate class of drugs. And there's sufficient evidence to show that TKIs are also effective in poor risk patients. But on our guidelines, we still always have for the poor risk category temsirolimus as the one drug. Yeah, but I think the real world data are different. Patients with metastatic kidney cancer who develop bone metastases, that's a little bit a scary situation in the sense that bone metastasis is really a prognostic adverse factor. So I do think that you really have to be on top of treatment of bone metastases. On the other hand, if it's widely metastatic bone mets, of course, you cannot give a local treatment or maybe for one specific single bone metastasis. So then you still have to rely on your systemic treatment. But if it's a patient with one or two single bone mets, and if you would be a little bit concerned about the efficacy of your systemic treatment, or you would be concerned about the fact that there's a high risk of fracturing in the immediate future, I do think that you should irradiate a single bone metastasis or two bone metastases. So you can still continue your TKI treatment, although we interrupt TKI treatment. We don't want to give it concomitantly based on some data that wound healing may be hampered. And in particular, if the field involves the gastrointestinal area, I think you have to be cautious and stop treatment with your TKI 3 days before and resume, for instance, 3 days afterwards, or a longer period of time, depending on the situation of the patient. But yes, I do think that for a single or a few bone mets, you should always consider either radiotherapy, or if it's in the vertebra, you can also consider neurosurgical or orthopedic treatments for one single metastasis, of course. Yeah. And if you then think about those patients with brain metastases, that's another issue. It's bothersome, of course. I don't think that a patient with metastatic kidney cancer who develops brain mets, that it immediately means that he will die very soon. It depends. If it's multiple brain metastases, I do think that the prognosis is really bad, and I wonder whether you should even contemplate irradiation. Personally, I think you have to wait carefully, but I would not be immediately in favor of irradiation, whole brain irradiation. However, you often with kidney cancer are confronted with patients who have one single brain met or up to 3 or 5. And depending on the size of the brain mets, I think stereotactic radiotherapy is a wonderful tool that is really enabling us to have local control of the brain mets. And patients, we do have patients that received stereotactic irradiation for 1 or for 2 single brain metastases, and they never reoccurred. And so I do think you have long-term survivors who will not have any problem anymore in the brains. Yeah, so you really have to, you don't always have to think that it will be immediately the end of the story for a specific patient. And in a single patient, you might even consider neurosurgery followed by irradiation. Depends a bit on the situation and of course on the situation of the other metastases.
So there are some subgroup of patients which are difficult to treat. First subgroup is bone metastatic patients. That's very difficult because first of all the TKI are not so active on the bone mets. And second, when patients have bone mets, it's painful, they can have fracture and so on. So one of the questions we still have is, should we use, in addition to TKI, biphosphonate or not? And this is still an open question. We are a little bit afraid, in France at least, to use biphosphonate in this patient population because of osteonecrosis of the jaw. We use them when there are a lot of bone mets. If not, we try not to use them and still look at these bone mets to radiotherapy in a specific spot. But that's the only thing we do differently from the other patients. Another group of patients which is difficult to treat are brain metastatic patients. And the reason why it's difficult, first of all, they have been excluded for most of the trial. So we don't have so much data on these patients. And second, we know that TKI in general can induce bleeding of the brain mets. So what we usually recommend to do and what we do is that we treat brain met first, usually by radiostereotaxic surgery or kind of surgery in a few patients, and then we apply TKI. It's still a poor prognosis group of patients.